I was saying to somebody before I attended this, agreed to attend this conference, it's probably a function of my age, but I've been at a lot of these conferences over the last 10, 15 years, where we talk about the importance of information, informed decision-making, data analytics, technology, and then we kind of go off and say that's been wonderful discussion, we've had great speakers, and then we've kind of fall into the traditional pattern of what Stephen Lewis refers to as, Canada, the country of pilot projects and reports, and that we're great at planning and then we're not very good at implementation. So I must say personally, I've been quite energized by the discussions, and I'm hoping that this panel will provide an opportunity for us to really look at what are some specific things that we can do with respect to moving forward. It was interesting, I don't know if you've read the Globe this morning, but on the editorial page, there are two articles. One is about a UBX, as you know, those of you who are in Toronto or come here frequently, the supposedly wonderful system of transportation from the airport to the city. And the analysis of it in the editorial said, here's a perfect example of this was a political imperative. The data was not analyzed, was not reviewed, and right now it's considered a failure. So they get about 2,000 riders a day. So that was the first article. The second article talks about LNG, and they talk about the fact that it's paralysis by analysis. So we have the one, there is no real attempt to really look at the data to arrive at a decision. The decision's made, and then you find out it's not. There's no real evidence to support it. The second one is, okay, we'll use as much evidence and we'll continue to generate evidence until somehow we get the answer that all of us are happy to accept. So for whoever, if anybody talked to the editorial board at the Globe, it was, I think, a very good and timely article. We are very privileged, I think, today to have a couple of panel members who have been here for the last day, but we're also joined by Chris Simpson, Dr. Chris Simpson from Kingston and Queen's University, and Dr. Joshua Tepper, who's CEO of the Quality Council. I'm not going to go into a big outline of their CVs. You have that information in your package. I just suffice it to say, I think they will bring a additional value-added perspective. The process that we're going to take for this, I'm going to ask each of the speakers to talk for probably a maximum of about 3 minutes on key reflections, either of what they've heard over the last day or so, as well as any observations they make generally about what are things we need to seriously consider as we're moving forward if we're going to make this the reality we all want. Based upon that, then what I'm going to ask each member of the panel to do is to identify one thing that they would do Monday morning to advance this. Very specific. Then what we're going to do is we're actually going to use the technology, the polling technology. So based upon the four things that people think are going to be important as of Monday morning to move forward on, we're going to ask you to rank those four. And we'll look at the results, generally how you all rank them, and then we will do another analysis ranked by grouping. So remember, we were asked to provide information. So to see if there is any a difference in the way in which particular profiled groups here assess what was important. Then we'll have some discussion among the panel. I've got some questions, and I know others will have, about, okay, how do we actually make this a reality and hit the ground running Monday morning? So I will turn it over. I think I'll start with Robyn, and then we will just move through the four panelists. You don't have to come up. I think you're quite comfortable sitting where you are.
Thanks very much, Janet. I've got to say, I've probably been around as long as Michael has, and so you go through these periods of, great joy that things are going to happen, and then great Great Depression when they don't. I have to say that in this meeting, this time, this room, I've actually had more hope than I've ever had. I think it's not should we, but how should we get going on this more than anything else. And I'm excited by the prospect of the kind of data that is now available, the rapidity with which it can be available, and then how that data can be used to actually provide, I'd say, directions in care. I thought about last night, and I thought, well, who is going to be the Canadian Tire for the healthcare system? And I wondered, is this going to be CIHR, who is the Canadian partner or the Canadian Tire for the healthcare system, or is it going to be something else? And if it is going to be CIHR, then I think that there needs to be quite a number of changes, of which I would love to elaborate upon. But before even getting to that point, what's going to be the motivation to go beyond just saying, yes, we should be doing this, we should be measuring, we should be analyzing this data? I think we will not get much further unless we do two things. One, this data has to be publicly available, all of it, and it has to be accessible and publicly available. CMS, the Center for Medicaid, now makes this available on a mobile for everybody in the United States, can actually look at the performance of a given hospital, how much a given doctor charges, and a variety of other quality indicators. That's where we need to go. If we don't go there, then we'll just be able to talk to ourselves again in another decade or so about should we will, but we have not yet got there. So we have to make it publicly available. The public deserves it. If they want to be educated about where we are with the healthcare system, they need it. The second thing I think we need to start using the data to pay for value. And if we do that, if we do those two things, then I think that we will have something to say.
Great to be here, and I've really enjoyed this conversation. I don't get a chance to spend 2 days at a meeting, so it's been a real treat for me to be able to listen to the conversation. For me, it's been, I guess the key learning is we've got a lot of data. I think we've all known that for a long time, but the data is primarily siloized, as to your point, in terms of organizations. I think the Travis piece, I think, was really resonated for me in terms of we talk a lot about patient-centered, and I think there was a piece not too long ago Andre Picard had in the Globe around the rhetoric around that, but the reality is it's not really patient-centered. And so I think the overarching theme for me is I'm very optimistic in this country right now. I think we have an opportunity to leapfrog from where we are in all of our data silos, to think about what's the next step. If we're going to own the OECD podium, then we have to use the information that we have differently. And that means, to your point, opening, but also the structure around that. As you heard me say yesterday, structure and governance are important. They allow us to focus and achieve results. Right now, we have a plethora of organizations. So I think leadership is critical for me. And leadership, by that I mean the vision to take our moonshot as a country, and to know that it's going to take us some time to get there. The data is the fuel. We have spent a lot of time in our history focusing on one piece of data, and that's primarily dollars and cents. And dollars and cents are important, we all know that. But there are other kinds of data points that are the currency that will allow us to achieve our moonshot. That is where I'm very optimistic that we can do that as a country. If we can focus on that goal of what we want that to look like in the future, and I think Travis has given us a great picture today of what that needs to look like. And I think that's what we need to step back from and think a little bit about. Culture is a huge issue as well. Culture across a number of organizations that is, focused on always thinking about the way we've always dealt with data. thinking about it's got to be perfect, it's got to be this and that. And I think it's what you've seen from Travis, is a willingness to take some risk, to think differently about that use of data, focused on how it actually helps people at the point of care. The tools and technology part, I'm not so worried about that. I think there's constant evolution. There's lots of good tools, but if we don't have a focus as a country on what we're trying to achieve, we will get similar results.
Thank you very much. Thanks for having me here today. I feel a loss that I haven't been able to participate in the last conference today. It's been obviously a tremendous conference and great people. Fortunately, I know people here that have been sending me amazing updates. This is what you're missing now. This is what you're missing now. It's sort of been like my Jewish mother with a guilt trip. As I think about this topic of value, I think to really unlock the value of the data analytics, we're going to have to solve probably 3 different tensions. The first tension is this quantity versus quality of the data. How are we going to resolve and parse the fact that not only, as Peter said, we have already so much data, we've got more data that will come online each and every day. It'll come in from wearables. It will come in from international sources. It will come in from databases that we never used to be able to link, and now we can. It will simply be logarithmic in terms of what we have available. The response from the system is often, I'm drowning. Berwick this year at IHI in his close said, there's about 10 things we need to do. And about number 3 on that list was cut about half of the indicators that we have because we're drowning people in indicators. When I go and talk to middle managers in our healthcare system, it's like, where do we begin to focus? And when I work with patients and I talk to patients and I sort of turn my screen around to them just like I'm supposed to do, and I involve them and I control T and pull up their lab values, control T brings up their lab values, and just like 5 years worth of data, it just spills out, and then I start clicking away and I'm popping up screens, I'm like, see your cholesterol, your hemoglobin A1C. Now what we look at is your EGFR, right? I'm trying to be patient-centered and all this, and I'm sharing the data, right? It's just overwhelming. So that we will have to balance the tension between the quality of the data that we want to share and the focus to the unbelievable sort of orgy of data that we now have available, and that's only going to go up. And then how do we access it, right? Most of our websites are increasingly trying to parse by audience, by date, by sector, by government priority. How are we going to organize that? If you think about it, the #1 search engine website landing page in the world is just a blank screen, right? It's Google, right? We spend hundreds of thousands of dollars thinking about how do we organize our website for people's data, and if you're a provider, go here. If you want English, go here. If you want French, go here, whatever. Google, you just log on. In fact, the city of Calgary, I understand, has the exact same interface when you go to the city of Calgary. It looks like a Google box. And so how do we navigate this is number 1. The second challenge is the inside-outside game. And, who is going to do this data? Who is going to be the driver of analytics? Is it going to be CIHR, Infoway, Health Quality Ontario, Ontario Hospital Association, Public Hospital Acts? Are they going to be the inside players, or is it going to be Yelp? Is it going to be ratemd.com? Is it going to be patientslikeme.com? Who's actually, and is it a choice? Is it a choice? We have ratemd.com that's sort of completely outside of sort of the healthcare system, really. No government funding that I'm aware of goes to it. I don't think my physician dues go to that. Or is it going to be like the Utah University in the United States with the Utah Academic Center, which actually puts up by individual physician every verbatim comment of patients? So this inside-outside game, who actually is going to be playing in this space? Is it private sector? Is it not? Is going to be a really interesting thing. And it's not necessarily a choice. But how do we navigate it so that when you're a patient, it's like, do I go to CIHR, or do I go to some third party who's going to sort of take advantage of the new open data and sort of create some type of other system? And how do we help the public and people navigate that? Is it going to be HQO, or is it going to be some other company that does that, that actually will get into the performance game and sort of do something that we can't do, or do it better than we do in some way? And what's the responsibility and role? The third thing is the transparency and privacy. And I think there was a good session last night on this. You know, everybody says, well, today's generation doesn't care about privacy anymore. And then people say, well, they don't care about it till they care about it and something horrible happens. Good article in the Washington Post about 3 months ago showing like the millions and millions of health records that got leaked last year. And, you know, you think even about the fantastic presentation we just had, you'd say, well, you know, what if somebody hacked that website? What difference would that make, right? You know, you hack some performance data. Well, if you actually were a boxer and you knew that somebody was injured or had a right rib fracture or had a contusion, boy, could you sort of exploit that in a game or in a boxing match? If you're betting on boxing matches and you could hack into the back end of that website and you got into the profile of a team, boy, could you start to bet differently on that data? Could you start to think differently? So, you know, we sort of say privacy, yeah, in this day and age, who cares? But actually there are implications. And when one of those athletes gets admitted to hospital, as has happened in the Greater Toronto area, or specifically a coach of a great team that is a customer and probably has data nested there, because I'm not sure it's just athletes, they get in, and we've had the incidents where people are going into their chart. So, you know, this privacy versus transparency thing is complicated. I think there are good pieces of documents and ideas out there. Privacy by design is one that I've been impressed with. There's many others, but that's the third tension we're going to have to solve. And the fourth and final one is less attention, to be honest, but we've got to figure out how we move from talking about patient engagement and saying this is about patient care and all that, to actually, you know, where's the patient on this panel? One of my board members very thoughtfully pointed out a session I'm holding in 2 weeks, and I talk a lot about patient engagement. And, you know, she appropriately sent me an email 8 seconds after the thing went out and said, so where's your patient? Thank you, Shelley. And she's right, like she's totally right. I blew it. You can put that in my performance evaluation. But it is this thing, like as committed as we are, A, we don't always live through on our commitment, and B, we're not always sure how to live through. So if we want to talk about patient engagement, you know, how are we going to make sure that conferences like this earn that patients included designation? Like every conference that we host has a patient included designation. Our landmark flagship conference does earn the patients included designation, but not every conference we hold does or sponsor, and that's got to change.
Well, thanks very much. I appreciate the invitation for sure to be here. I thought I'd bring sort of just the role of the physician to the discussion, and I think that's probably what the intention was by inviting me to be here. Certainly, I think you know, those who are from the outside looking in to the clinical world perhaps see physicians more as barriers to change than agents of change, although there are a lot of great physician champions, and I think there's a physician champion attached to probably most major change initiatives in healthcare. But as a group, we're often seen as barriers to change or something that needs to be overcome. But I think, you know, physicians do respond to meaningful performance data, particularly if it's attached to patient outcomes, if it's important to them as a bedside clinician, and particularly if it's timely. So data on how we performed 2 years ago is interesting. It may help in long-term planning, but it doesn't help me with the patient in front of me today. There's a very interesting guy who many of you may have met, who's the CEO of the Cleveland Clinic, Toby Cosgrove. He's a cardiac surgeon. He's a very kind of straightforward guy. You kind of meet him and you say, wow, this guy's the CEO of the Cleveland Clinic. He sounds like you know, my neighbor that I grew up on the farm with. But he says, well, we asked him, how did you transform your organization to this really high-performing organization? And he said, I just showed the physicians their data. And that was his answer. And you know, when you think about it, when we show physicians their data on their performance, things like, you know, if I showed you as a family physician all the hemoglobin A1Cs on your patient and how you compared to all of the other hemoglobin A1Cs that the other doctors have, you don't have to actually put in a plan to change. It auto-fixes itself. You know, we hate to be below average. You show us that we're below average and it gets fixed. And in fact, I've seen this in family health teams where they've done these very simple interventions where they just showed people how, you know, important patient outcome performance measures compared to other providers, and then they just remeasure it again in 6 months, no intervention, and it's fixed. And there's a lot of potential, I think, for that, if we can figure out how to get meaningful data in the hands of physicians in a timely way at the bedside. Now, I would submit that the average physician's day, in their workflow, in their interactions with patients, in their interactions with other healthcare providers, don't really have meaningful data related to their performance or their system's performance in a way that they can act on in the moment. So how can we bring real, live, contextualized data and analytics into doctors' professional lives? You think about, maybe an app that tells us our test utilization compared to our peers in real time. An app that family doctors can access to get current wait time data for specialists. I mean, this exists sporadically. Or for those of you who live the absolute horrificness of patient flow these days, in this days of hospital over congestion and gridlock, everybody knows that the subtle decisions that physicians make are probably 70 or 80% of the patient flow problem. So, I'm not suggesting we put an anklet and track physician movement or anything, and Janet would love to do that, I'm sure. But it speaks to the ownership of the problem by physicians. And, rather than being seen as barriers, I think what we need to see them as is potential fixers or contributors to the fix of the problem if we can only put these data in their hands in a meaningful way. So I think physicians and their organizations, and I don't mean the union organizations like OMA, but physicians all belong to their specialty societies. These are voluntary membership dues paid organizations that are doing some really good work. And I think that these organizations and their members can play a big role. You think of organizations, just from my own experience, like the Wait Time Alliance. I mean, this is an organization of 17 specialty societies that has reported, at a fairly high level, wait time data on provinces for the last 10 years. We generate report cards. Arguably, by just reporting the data, we've had some impact on some of the improvements that we've seen. You heard from Rick Birtwistle about Simpson, the database that is helping use family doctors' EMR data to help us understand better people who have chronic care challenges and their trajectories. And the Canadian Cardiovascular Society, I'm a cardiologist, I don't know whether Tracy Johnson's here, but a few years ago, we couldn't even decide on a common data definition on what was a wait time for cardiac surgery. They were different in every province. And the Canadian Cardiovascular Society, just this bunch of average docs, they developed a set of common data definitions for important measures in quality across the country, standardized them, developed an e-catalog of quality indicators. And in a few months, in partnership with CIHR, the CCS is going to publish a nationwide report card on TAVI, the transaortic valve implant procedures that are done in a non-surgical way in all 25 centers. Now, it was like worse than negotiating the TPP to get all the data, out there, but it's happening, and this is a physician kind of driven thing. So I think we can bring value, and I'd like to really explore how we can bring more value, and how we can redefine our relationship with organizations like CIHR and others, less as a client, but more as partners. What value can we bring? What value can they bring? How can we work together? And I think by doing that, it feeds back to our profession and our professional culture in a way that helps us, I think, transform our professionalism into one that is more of a civic professionalism, that sort of accepts responsibility for clinicians at the front line and their organizations to be stewards of the system and for system improvement. So that's my 2 cents.
Well, thank you all for those comments. I mean, I think it's very clear there is a much more upbeat, I would argue, an optimistic view of where we are and where we have an opportunity to go. I think there was also a number of comments, I would just say, around the issue of focus. So much more need to define where we're going, whether it was referred to by Peter's leadership. Others by, pick the things you want to work on and then relentlessly look at them. I was reminded when I was thinking of last night's session, for example, and I heard a number, I don't know whether you heard people, as the presentation was going on, well, that's fine for them, but in healthcare, you can't set these type of priorities and you can't do this and you can't do that. I don't disagree that there are some differences, but the message last night was pretty clear about where you're going, focus on it, and relentlessly drive to get there and using information to support you moving in that direction. And I think we heard that in our previous session today. So I think what I'll ask now is we're going to move into the shortly into the polling section of this conference. But I want to now turn back to each of the speakers, and in, I would say, a very short sentence, a couple of words, whatever, one specific thing that we can take away and start on Monday morning that would get us to where we all believe we need to go, which is accelerating the path forward. I'll start with you, Robyn.
Well, I've got a long wish list, but I think to keep us motivated and in the right direction, I think public access to the data, and I mean big P public access to the data. Not find it on my website. I'll dare you to find it.
So public access to the data.
Well, to the metrics, I think.
To the what?
To the metrics, to quality metrics at a provider and at a provider level.
Peter.
So as Travis said, what we're trying to do is bring people together, entrepreneurs, business, universities, government, the communities across the sectors to think differently about how we can evolve the technologies that are there, and ultimately I think it's about partnerships. So if we can think about how we can bolt on what we are, something that allows us to use the various pieces of information and the significant horsepower and people and resource that we have in all of these fabulous organizations to look at how we can partner to achieve that common goal. So I think for me it's about partnership.
Josh.
I think maybe it's a variation or sub-theme of Peter's. I would say that we need to add a patient and a provider to every of our analytical design processes at the beginning. Not like after we've got it sort of baked and then we'll do a quick consultation 2 years later, but patient and provider at the beginning of all of our analytic design processes and conversations. And again, because the usability is just not there. If I actually had to process walk you through what it takes for me, if I have a patient come in and say, oh, I was in a merge and I had a CT scan and some blood work done, if I had to walk you through what it takes me to try to track that down, I'm in the one EMR, I have to exit, I have to log in to the hospital EMR, then it turns out it's not that, so I have to go to Connect GTA, then it turns out their ultrasound was done in a community lab, so I can't get it no matter what I do, right? Like, you would be stunned. And for patients, I had a patient with cancer, and this was one of the few hospitals that actually has an EMR accessible. I was trying to help her get access to her own EMR, and I just couldn't actually get her access. And so I don't have access, and she doesn't have access. So patient and provider on the design of every analytic usability study or process that we're doing, a project.
Chris.
And for me, it's the same thing too, partnerships. And, going back to my previous comments, specifically partnerships, I think with this emerging large number of physician organizations that are interested in quality improvement, that are actually, from their member surveys, they know that doctors are interested in quality improvement and using data and analytics to improve the system. And I think if I had one wish, it would be for every national organization to matchmake with do an environmental scan and look at the organizations out there that are completely aligned with what you want to do, and partner with them. There's lots and lots of opportunities, and the physician community is more receptive, I think, than ever before. Just look at choosing wisely. I mean, this was absolutely embraced by the physician community very, very enthusiastically. So I think the mood is there for partnership from our side.
Okay, I'll try to summarize these four, because this is what you're going to be voting on in terms of priority, and then we'll have some further discussion. There's the issue of public access to quality metrics. So that is making quality metrics publicly accessible. The second one was partnering, but if I understand, Peter, from your comments, is partnering with all the key stakeholders. So you're talking private industry, entrepreneurs, researchers, providers, politicians, you name it. So a very broad area of partnering with the key stakeholders that are going to advance the agenda. The third one raised by Josh was to add a patient provider to every design analytic process. At the beginning. And the fourth one was also along the theme of partnering, but I'll subdivide this one, which is really to differentiate it from the previous one on partnering, is for active partnering with physician organizations across the country. So there are 4 ideas that have been advanced as what we need to do differently starting Monday morning. So the process for doing this, you have your little, I was going to say doohickeys, now there's a real scientific, a nice piece of technology on your table, and so you will rank the 4 of them, the highest ranking being number 1, and so the lowest ranking number 4. And we will give you about 30 seconds to complete that. Then the results will come in, and we will discuss. We'll look at them first of all to say, okay, this is how you rank them generally. And then the group is also, our technical people have also agreed to do a crosstab, and so we will see how it breaks down that way. So first, your primary role, and you will. That's up on the screen there, your primary role. And then there are the 4. You want me to repeat them, or have we got a slide that shows what they are?
We need to answer the primary role one first.
Yes. So we can move on. Answer that one, yes. Then we'll move on into the, well, this is pretty much, well, it's not too different from what was, if it is, we've got some significantly different from yesterday. We've got some, people may have just decided they're no longer other, they're something else. And these are the 4 action items. We're saying starting Monday, what you would focus on. I want you to prioritize these. The highest priority, give it a 1, the lowest priority a 4. So these are the, not unlike actually the 4, but you'll see that public access was ranked 1. I'm hoping this is not just, this is an artifact of how you entered the numbers, but this is what people actually feel. But we can have this discussion after we actually look at these results.
The 225s were different heights.
Yeah. This is interesting to see the differences between various groups. So maybe what I'll do is we'll first go back to the other ranking. And ask, maybe we'll just have some comments by the members of the panel about this ranking here.
So,
Josh?
I mean, first thought, I'm not sure those are statistically significant. And it's sort of, it's a lot like the Iowa poll between the Democratic side there. Pretty same. You know, I think the other, the exercise is good. I appreciate the exercise and the interactive nature. I do think it's a bit of a fool's choice. The idea that we should be doing one of these and not all of them is a problem. And I thought your comments at the beginning, Janet, about, boy, we've been throwing ourselves at this for a long time, was a very thoughtful one. And I think part of the problem and part of the reason we haven't made better progress is we fall into that policy trap of thinking there's a magic bullet. We fall into the policy trap of thinking there's unanswered, that if we went back on Monday and picked one of 4 options or one of 7 options, we're going to do it. And I think the reality is, for something as complicated as this topic, for something that's as transformative with as many moving parts and ethical issues and technical issues as this part, it won't be one. And no decision maker and no clinician should go back and sort of think they can pick one. They got to probably do these 4 and 3 others to actually start to see the yardstick start to move. And I think it is a bit of a fool's choice. I mean, again, not to dismiss it, but I think there's always that risk of policymakers sort of trying to pick the key, and it's actually, it's a ring of keys.
I don't disagree with you. I'll play a devil's advocate, though. People would also say a healthcare cops out and they just put a whole bunch of things and they don't actually action it. And I think it was very clear at the dinner last night that there are a few things, and you focus, you focus, you focus. So how do we, I guess, how do you actually balance? I don't think, my assessment would be, I don't think anybody would say all of these aren't important. But how do you actually, and there may be others that the audience feels are important that haven't been addressed here, and we should probably consider that as well. But how do you actually ensure that you've got a few critical things that you think are absolutely essential, and that you move on those? So, I mean...
I look at it in the reverse, and it's that, we've had the best data, and I don't say this just to say it. I mean, we have the best data in the world here in Canada. There's very, very few countries that have population-level data on their healthcare system. And why is it that we make such little use of that data, relatively speaking? It isn't really used, I think, to drive the day-to-day healthcare delivery. And that, to me, is really problematic. And I don't think that we talk about transforming the system, we talk about a lot of stuff, but I think that this inability to, we have this data, we don't use it, so why is it that we don't use it? And I think one of it is that we aren't actually paying, we don't fund in relationship to value or outcome. And I think we have to start moving along that pathway to create a pull. In order to fund for outcomes or value, you have to measure it. And suddenly that matters. And so I think that won't be the earliest win, but making data so that it's out there, people are using it. Now they start caring about the quality of it. And if it's available to the public, that's one way of actually using it. And another is to use it to decide how much people get paid. And so those are very high stakes ways of using that data. And that's why I'm pushing on that button as being one button that we haven't pushed on. We've been very secretive about all this, and we've left the Canadian public being, I'd say, relatively naive. And so now you have parallel systems like Rate Your Doctor and everything, because they can't get the information they want, and they're a fairly educated bunch. So I agree, it's not one silver bullet, but there's got to be some things that we're going to change as of Monday morning that we haven't changed in the past 2 decades.
Thank you for that. I was thinking if Vickie had been here, as you know, Vickie's going off to Australia, South Australia, to be the Chief Transformation Officer. And if you go onto the South Australia Health website, you can see their transformation plan. And one of the things that really struck me when I read it and talked to them over there is the fact that the minister is out in front of that plan. And he will go out into communities and say, we are repurposing your hospital, and here's the data. And you don't have enough volumes to support this, you can't do this, you can't do this. And the public those data are out there. People have, I mean, they don't, I'm not saying they're all happy and everything isn't sweetness and light, but the data is actually used to drive their action plan very, very clearly. And people understand, in particular the public, I mean, they're very transparent about what the outcomes are, what the performance is, what the volumes are, what the costs are, and a whole variety of other things. And it makes it, it does make it somewhat easier, they've said to me, about coming to difficult decisions. Do you? Any comments that you have, Peter, just on this?
Oh, well, I don't know anything. I'm actually just trying to change some stuff to get better outcomes for patients, and it's really hard to change things. It's really, really hard, and everybody talks about wanting things to be different, except when it comes to them. And so, you know, we've got to think differently, you know, about the problem, and I think data is very much inside baseball, you know, and most people, you know, their eyes glaze over, except for those of us who, you know, like and understand algorithms. And most people have absolutely no interest in what we're talking about, but they're interested in the news around gravitational waves because it changes our way of thinking about the universe, and we need to describe a way to think about the healthcare universe differently. And when we talk about a pan-Canadian ecosystem, it's really trying to describe that level of complexity that we've been talking about that isn't going away. It's not about one application that's going to solve all of our problems. It's not about one particular company that's going to lay the platform down. It's about dealing with what are the issues that it will take in this country to deal with the privacy, the regulatory issues, the data issues in a sea of proliferation of applications, and that's not going to go away. How do we harness that ecosystem to create value for individuals who actually have to live through their disease process so that they have it in their hands, that they can control that information with their provider as their trusted advisor in the future? How do we create that? That ecosystem is that gravitational wave shift that we need in this country that really allows us to leapfrog over this constant argument that we have over data.
Josh?
You know, I guess one comment, actually, I think Chris and I were chatting as we tried to sort out our ordering as well. You know, the public access is one. The next three actually talk a lot about partnerships and this idea of together. Like they're variations on a theme. And I think that's a very, very important part of this is figuring out is that connectivity, which again is reflected in 2, 3, and 4. So it's less about 4 choices, but 1 very much around number 2 and then variations of number 2 in the last 2 pieces, as long as we're willing to acknowledge providers and patients as part of stakeholders and part of that group. So that would just be the other observation.
And we certainly heard it both in the previous presentation, the one last night, and actually a number of the presenters yesterday. They all referred to partnering, whether it's patients, other groups, other organizations. So I think you're right there that it is absolutely critical. In fact, you could probably add, 2, 3, and 4 have some aspect of partnering in all of them. Chris?
I wonder if maybe the answers might have been ranked differently, or even our 4 solutions may have been different if the question had been posed, how are we going to make better use of data analytics for the creation of evidence-based policy in Canada versus how are we going to deliver better care for patients? And I know they're intimately connected, but the way that those 2 things are operationalized could be very different, both in terms of timelines, the tools you need. And I think we need both, but the perspective I was trying to bring is that there's an opportunity, I think, by these partnerships to really accelerate the move to have meaningful data and analytics right at the bedside. To me, that's what's exciting about this. I mean, that inspires care providers. Not that health policy isn't important. We need good policy to determine how to fund things and how to plan for a sustainable future. But I think the real missed opportunity, and maybe actually the easiest thing to achieve, is that bedside piece.
So a real distinction between the use of data and evidence to support policy, and then there's practice.
Yeah.
Yeah.
Because I think both you, Chris, and Peter actually said something I think that really, to me, resonated, and that is that you really need to decide where the focus is. The data is just a vehicle to get you there, just like technology is as well. But it really is, you need to focus. And I wouldn't have thought it would be possible to actually pick a focus in healthcare. I had the privilege of going off to one of these big European meetings, and in fact, they've actually picked in the EU a focus of saying, I'm going to give each person 2 year quality years more. And they've organized, like we talk provinces, they're talking about countries in the EU focusing around that. What is it we're going to do concretely to get there? And of course, data is part of the equation, of course, and technology partnership and so on and so forth. But it seems like almost we've lacked that focus. We have an opportunity, I think, to have that focus now with a new sort of health accord and a new different sort of orientation to healthcare in the country. And it would be great to actually to focus on something like that. Like let's take the adverse event rate. Let's reduce that by 1%. We're at about 6.5%. Can we reduce it by 1% in let's say 3 years? What would it take to do that?
Well, I know there was some discussion at dinner and after dinner, before dinner, about, okay, we're in a unique opportunity in the country now. We have a new accord, potential for a new accord, and the way, is it possible to actually use data and information in a way to drive the accord in a way that we've not done before? And that would it be a missed opportunity if we didn't actually do that? Is that one of the issues that that came up in the past? And certainly I think people would say that one of the challenges with the accord before, there were certainly some very targets set out and other things. They kind of got lost. And then it was take your money and go away. And now saying, okay, if we're going to spend this amount of money, what's the performance that we're expecting, and how do we measure it? I think what I'd like to do now is maybe turn it over to the audience. Specifically, excuse me, I want to ask, are there things here? There's been 4 things that have been identified. I think everybody's agreed that that's not all. There can be a lot more. But are there other things that people feel that starting Monday morning we should really be focusing on? And not just like have another meeting, or are there very specific things that we should take into account? Because I mean, I go back to the whole purpose of this conference is to actually identify a path forward. And from my point of view, and I think we'd all agree that a path forward isn't just saying we're going to go there, without saying how are we actually going to get there. And so are there specific comments, suggestions about how we actually are going to get to this path forward, this vision that we all see?
I actually have a suggestion.
Okay.
I would add to the tagline, if you want, one condition at a time. So if you,
okay.
So I'll suggest a way forward, maybe, because I agree with all the priorities in a sense. We're going to line them all up. The question is how you get there. And for me, like I said in the talk yesterday, there are 15 federal agencies all going in different directions. And,
yeah.
I'll give you an example. NCE, CIHR, all build networks. Guess what? We have a country of networks, and they're all reinventing the wheel. They all function differently. Imagine a situation where we decided to pick one. Dementia, heart failure, a cardiovascular network that has heart failure, arrhythmias, whatever, Chris, to you. And then in this network, it has a goal to do what Robyn said, which is decrease mortality by X and quality of life by Y, and we're going to fix it. Every province aligns a network, it aligns together, and we have a national goal. So the point is, and that's what Great Britain did, right? The UK NHS aligned its whole country along networks. And it's because the Minister of Health decided, you know what, cancer care sucks in this country. And they fixed it all, starting with cardiovascular care, and then started to build NHS networks. It aligns policy, it aligns the doctors, the nurses, the health providers, along conditions. And again, if you're looking for more evidence of that, Michael Porter wrote a great book just recently describing what value means. And a big thing for value for him was you aligned it for the patient within conditions. Because otherwise, you're too wide or too narrow, right? That was the kind of quote. And you can't think that, and as a practitioner, you see a patient in front of you. As a policymaker, I know it's wider, but networks help, or the thinking around a condition helps. And the condition could be chronic disease management. It doesn't have to be disease. Networks, and aligning the federal with the provincial. Most provinces, except for Alberta, aren't thinking this way yet. Just saying.
So the importance of networks. Yeah. Other comments?
Over here?
Oh, okay, yes.
So I'd just like to speak to that because I'm from the Canadian Partnership Against Cancer. It's actually implemented put together to implement a cancer control strategy, and that's really the foundation of its work, is to bring the networks together. I think it has been successful. It's not all magic and fairy dust, as others have suggested, but there has been some ability to move together, recognizing that the provinces still have complete control over any decisions that are made in their own jurisdictions. Having said that, we haven't lost in this. We're talking today like we have all this great data, we have the best data in the world. We haven't talked about the fact that the data that we have is great if you want to ask for it within each individual silo. But to actually link up what's happened with diagnosis to others, we haven't talked about that barrier. And one of the things I'd like to put on the table is, should we be thinking about having penalties for data hoarding in the same way as we have penalties for data release?
Thank you, Heather.
Data hoarders.
She said they must, yeah, that was great.
Penalties.
Yeah.
That would turn the world on its head.
That would, Heather mentioned that to me last night. I thought, well, that's an interesting perspective. I mean, I think it's a good one, but how do you go about doing something like that? Pardon me? Shaming, public shaming, yes. Well, of course, that gets to the issue that Robyn raised and others is the transparency and the public availability of information. And again, you see it, for example, I go back to Australia. Look at how they've been able to get their influenza immunization rates up. I mean, they literally publicly shame the states, and they'll do it in individual jurisdictions within the states as to what their immunization rates are. And it's worked for them. I'm not saying it works for everybody, but I think it's something to consider. Yes.
So one of my takeaways from the last 2 days, both last night and this morning, was that laser focus around scope and around, you know, the whole analytics agenda. And I can't argue with these points on this list, but for me they're very, very broad. So I'll just pick on one word, like partnerships. Assuming that's a very good concept, where do we start? Who do we partner with and for what purpose, in other words? So how do we get that finer point on each of these concepts so we can get immediate value and be agile, start quickly, pivot if necessary, as we heard again this morning? Just share a story, give credit where credit's due. I heard the CEO of Stanford Medical Center speak about 8 months ago, and it was at a health analytics event. And he was speaking to that agenda in the context of his organization. And what he did was he tied the investment in analytics to the strategic plan. So the strategic plan had financial elements in it. It had elements of clinical programs and clinical program management. It had aspects of patients and patient satisfaction and patient engagement. So they would set their strategic objectives on the short and long term, and then build the analytics or put the money into the analytics to support those strategic objectives so they could measure, monitor, manage those. I do acknowledge you'll need some analytics up front to understand your strategy, so you know there's both sides of that coin. But it was just one illustration of how one CEO used his strategic plan to get that laser focus around scope, and I think that's partly what we're missing in these concepts. And in a sense, maybe in some of the organizations. I mean, I like the concept of networks, but again, we need that laser focus.
If I could just make a comment, and then I'll pass it to Chris. I mean, I think I will accept some of the blame for the fact that I rolled these up into fairly high order things, but I think giving credit to both certainly Josh and Chris, I mean, there were very specific examples of what groups you would partner with. So I think if we then take the comments that were made earlier about networks, I mean, having come from Alberta, our strategic clinical networks in Alberta, they are along particular conditions or groupings, and those are very focused, but the partnering within those is very focused. So they say there's got to be patients in all of them, but if you're doing the, for instance, the bone and joint strategic clinical network will have different partners than the cardiac network will have. Patients is common to all of them, clinicians is common to all of them, but the other partnering could be quite different. So I guess what I'm saying, I think there's an opportunity to take a laser focus through something like a network, and also focus on things like what are the key stakeholders that you're actually going to partner with in order to advance that. Chris, and then Josh.
Yeah, I think just to reflect back on a couple of the previous comments, I think one of the difficulties that we have, and one of the reasons why it's difficult to compare us to the NHS experience, is this federated model. And many of us who have a national view of things always get hung up when it comes to making these things happen, because there's always a province or two who sees it differently or is on a different timeline. So coming up with a national plan is always going to be really, really difficult and messy. But I strongly believe that there are lots and lots of organizations that are perfectly aligned with each other, but they don't know that each other exist. And they can't quite bring it to the finish line by themselves, but together they could. Now, one very tangible example is, again, going back to the Wait Time Alliance example, we had the Canadian Association of Gastroenterology that were very interested in publicly reporting wait times for colonoscopy. So we got them together with all the wait time coordinators in all the provinces. And Newfoundland and Labrador said, that's exactly what we'd like to do, but we just don't have the resources to do it. So they got together, and 6 months later, Newfoundland and Labrador is the only province in Canada reporting publicly wait times for colonoscopy. And it happened just as simple and as organically as that. So I really think, these at the risk of sounding, kind of a little bit too pragmatic, I think the low-hanging fruit is really finding these alignments between organizations that are completely, in sync with each other, but they just, to your country of pilot projects comment, they just don't know that each other exists and that they're working toward the same thing. They just need to be brought together.
Thank you. And that follows up, you remember some comments yesterday about the importance of spread. And that, there's in fact, I think one of the, I'm not sure who said it yesterday, but the fact that one jurisdiction won't know what the other's doing. And in fact, I would go so far as to say some jurisdictions actually don't want to know what another jurisdiction is doing it. So the model that we have can be good in some ways, but in other ways can actually work against trying to do the things that we think are important, like spread. Josh?
2 or 3 quick thoughts. I completely support the need for focus. I love the idea of networks. I think there's maybe 2 or 3 quick caveats, though, to keep in mind as we sort of lean into that. So one of the challenges is that patients don't always fall neatly into it. And so it's very nice to talk about, let's start with dementia, or let's link our cardiac networks. Unfortunately, a lot of our patients have dementia and cardiac problems and diabetes and income problems. And so it's just, again, as we create this focus, it does work for a certain group of patients who come in sort of fairly unidimensional and just have one issue, but the problem of getting too streamlined and too focused and collecting is as people live longer, as chronic diseases, including things like cancer, HIV, kidney disease, things that used to be quite short-term illnesses, become chronic disease. The fact is some of this laser-like focus gets hard, and as clinicians, you go to your COPD guidelines, chronic obstructive pulmonary disease, you go to your hypertension guidelines, both of them are probably over 200 pages with over 70 recommendations each, and then you go to your diabetes ones, which are even larger. I think they win the prize. It's close, though, to be fair, to the heart and stroke. It's really tough because the patients don't come in uniformly. So that's the number one. The number two that I think is a risk, again, it's not to take away, but just something to be cognizant of, is I think there's sometimes an inclination as we create these networks and this focus, is we tend to go towards diseases. People, the speaker mentioned dementia or whatever. There's also a whole role for prevention. there's also a whole population health role. And just to make sure that the same networks that we create move upstream and also look downstream, post-disease into chronic disease, and post, what people sometimes, we can argue about the term survivorship or post-survivorship sort of stuff. So again, just to make sure that as we move towards laser-like focus, we don't lose those broader population health. And then the third is, as we do it, is just to make sure that they're not networks for the sake of networks, but as Robyn and others have said, to a stated goal of quality goal. Is it for better access? Is it for a better health outcome? Is it for better safety, like an adverse event? But just always to tie it back. It's not partnership for partnerships any more than it's data for data.
I know there's okay.
Yeah, hi, Mike Scholl from ISIS. So I think most of us would agree with a lot of what's been said around better access to data, public reporting of the metrics where they exist and so on. But one of the things that I think hasn't been said is there's some of the limitations around the metrics that we have, not just in terms of whether they're evidence-based or and so on, but a denominator problem. For a physician's practice, the metrics will be your performance with respect to the patients you happen to have that month or that 6 months or that week or that day in your practice. There's no population lens. Who should you be seeing? What population you're responsible for? The same thing goes for our hospitals. If you look at their performance on hips and knees, it's the denominator is whoever they happen to do in that period of time, not who actually needs the performance, the procedures. Networks could also be limited to numerators, like who happened to get cardiac care, who happened to get dementia care, not who needs it. And we have a real problem in this country with health inequities. And I don't think anything that we're talking about would actually help to narrow those inequities if we don't start to bring a population lens to all of the work that we do, whether it's hospitals or primary care practices. Where there is data at a population level, it tends to be reported at a unit that is not actually accountable or able to intervene at a population level, whether it's at a provincial level or at a LHIN level, Ontario, or similar health region. Typically, they lack the sort of tools to intervene effectively to drive those down. So I wonder what your thoughts are about bringing that population lens and a population accountability down to the provider level. I certainly, I'm an emerge doc. I work in an emergency department. I have no sense of who my it's the patients who happen to show up that day. Now, that might be a particular, skewed example for an emergency physician, but I think most family docs similarly would not sort of have a sense of who the population is that they should be caring for, or cardiologists in a hospital and so on. So I guess the question is, can issues around value help drive an accountability at a population level?
What do you think?
Yeah, it's a great comment, Michael. And as you know, there are a lot of clinicians who are very tuned into the social determinants of health, and guys like Gary Block at St. Mike's and others who talk about prescribing money, and have clinics that are very deliberately designed to try to address the unique challenges that present in socially disadvantaged populations. And as they develop these data sets, from the ground up, where can they meet, the big data as it comes down, and where do they meet in the middle in a way that sort of informs bedside clinical practice, but allows us to measure what is the impact that these interventions are having, at the population level. I think it's really exciting, but it comes down again to sort of bridging this divide between the data that sort of feeds into the health policy sort of network and the data that is generated from or inspired by the front line.
It's a really good point, Michael, and I think that's where people are trying to move. If you look at the United States and you look at an ACO model, if you take a look at sort of what Ontario is talking about in sub-LHIN models, I think that's where people are trying to go, because otherwise, even to the, Chris is a good example. I happen to be fortunate to work in the clinic that Gary's at, and we do, if you're my patient, and if I've been educated by Gary, you're fortunate enough to have access to our income specialist team who will help you fill out your income taxes and stuff. But boy, if you don't get into my family health team, or if I don't even know that you're out there trying to get in and don't have a family doctor, you're sort of out of luck. And so I think your question is very, very good, is how do we actually start to use data? And I personally, I guess I defer to some others, but my own view is that data is out there, but how do we bridge that divide between what I think often becomes if you're an executive director or a CEO of a hospital, you care very much about what happens to the patients who make it through that door. Adverse events, timeliness, all of that. What you're not necessarily have the data pushed to you is what's about that community 3 blocks away as somebody who desperately should be inside and for whatever variety of reasons isn't. And that's not your fiduciary governance responsibility. You know, it's like somebody I saw on Twitter, a physician sort of said, you know, I just keep my eye on the patients in my waiting room. That's my goal. And I sort of thought, I got the philosophy. Like, it sort of, in some ways I was like super sympathetic to it, but I also thought, boy, that's exactly the problem. What about everybody who can't make it in?
Is there anybody here from Providence in Vancouver? Because I know St. Paul's in Vancouver has really has tried to look at that, because you deal with a large portion of the downtown east side population, don't you? So do you use population data?
Hi there, it's Yoel Robyn's Paradise from Providence. It's an interesting question. The answer is yes, but. Because of course there's, the access information around the socioeconomic information maybe in data sets that are not part of our health system's access points. And you're right, we have utilization data on who we see, but not necessarily the points on who we don't. What becomes interesting for us is that we're rebuilding our new hospital over the next few years, and all of this begs questions around what the role of the acute sector should be. And these are interesting questions, and I think we're trying to do that work, but we have significant gaps.
And I think this has been pointed out by a number of people, the fact that the data may exist, information may exist, but it's highly siloized. I always talk about the fact that the healthcare system, I use that term loosely, is probably the most siloized system anywhere. And while we may be very good at collecting data and information, the ability or the willingness, and I don't necessarily mean that in a pejorative sense, to share that information. There are all kinds of barriers associated with sharing information. And if you particularly look, as identified, some of the social determinants information which doesn't even exist within the realm of the health portfolios. I mean, this is a policy question as well as an operating question. Makes it very, very difficult to make informed decisions about what you're going to do for care. Yes?
From Alberta Health Services. These are really big picture things that are hard to move, and I think I wonder what people's perspective is on just starting at how do we improve data literacy for the people who have the information maybe at point of care. How do I have them ask the right questions so that they start to want the data and start to pay more attention about what they're putting in? Because I think there's a whole piece in the health system that we haven't got yet about how do we get people to learn and understand what the data is telling them rather than just skipping over that piece.
Comments, anybody?
Yeah, and there's confidence in the data too, right? I mean, the typical person who is reluctant to change goes through like the 5 stages of grief, right? Like first there's denial, the data are wrong, right? And then all the way through to stage 5 where it's acceptance. But the culture really needs to be that data are not perfect. They should generate more questions perhaps than they answer, and more discussion. And it's really a cultural question, and I think that's your point, is how do we sort of put all of this information in some sort of a cultural perspective that it can be useful to us, rather than having the end users feel that they're somehow going to be punished or judged or other negative words attached to it. It should be a positive experience for everybody.
Robyn.
I think it's a great question. I thought that the Conduct presentation actually just showed you take it to the final yard. So you have the data, you take the data, you analyze the data, and on the basis of that, you provide customized kind of recommendations. I think there's huge power in that, just immense power, and I think that's where we should be heading.
Okay, well, I've been given the the noose. So I'd like to close off this session first by thanking the panelists. I think their insights and comments are extremely helpful. I would also like to thank the audience, not just for participating in the poll, but for your comments and observations about ways in which we can actually move forward in a very explicit way. What I think will happen now is we'll take all of that information and certainly look at identifying where are the opportunities for moving forward, and then perhaps engage with some of you on particular matters, and then see where we go from here. The only thing I would make a commitment to, and I haven't talked to the conference organizers about this, is I don't want to have another conference like this in a year from now, and we're talking about these issues again. Hopefully, we may talk about them, but it will be within the lens of what's actually been done since the last time we met. So thank you very much.